Hello everyone, welcome. This is Lisa Johnson from Everbridge here for today's webinar, Best Practices for Active Drill for Active Shooter Preparedness with Steve Crimando. Thank you again for joining us. My name is Lisa Johnson. I'll be your moderator for today. And one of the things that we might have a chance to do this year is to meet face-to-face. I've gone to several conferences, HIMSS and the American Telemedicine Conference. The ones in red are the ones that I'm heading towards. I'll be at the American College of Emergency Physicians Conference in October in DC, and also the National Healthcare Coalition Conference in San Diego in November. So if you get a chance to stop by our booth and say hello, please do. So I did want to cover, one of the reasons why we're here today is those CMS emergency preparedness guidelines are coming. The deadline is on November 15th, and if we're not ready by then CMS might do something to us. So active shooter is one of the more popular drills that hospitals are doing as they prepare, and there is a reason for that. I won't go into the details because Steve will cover it in more detail in a minute. But just 4 days ago, there was an active shooter incident in, I'm going to say the name wrong, in Ocala, Florida. A man took a gun from a police officer and shot a nurse. And then that's sort of the bad side of it, but the good side of it is in Harrisburg, Pennsylvania, this coming weekend, they're actually going to be doing an active shooter drill so that they are ready in case the worst happens. I do want to introduce our speaker, Steve Crimando. He is internationally known as an educator, and he works in all different levels of emergency preparedness, crisis management, disaster response. He's a trauma specialist, FEMA trained, and he's frequently called upon by law enforcement agencies, the media, and the courts to provide insight on workplace, school, and community violence. Welcome, Steve.
Lisa, thanks so much for having me back, and thank you everyone for joining us on the call today. I want to kind of jump into the presentation pretty quickly. Lisa, I'll wait for you to pass control over for the slides, and
you should have it.
Away we go. Yes, I do. I'm good to go. As Lisa mentioned, the slides will be available to everyone after the fact, so I understand there's a lot of material on them. And the other thing to say, kind of a starting place, is I certainly imagine that there are folks on the line with all different levels of experience and expertise around things like drills and exercises, especially active shooter drills and exercises. We'll have some participants on the call whose organizations are thinking and planning, moving towards something like a full-scale drill. And there are probably folks on the line who've been there, done that, and the organizations have already done those sort of activities and maybe have done a few of those and are very, very much expert. But the other thing in terms of an operational assumption is that when we talk about drills, they're one of the last iterations of your exercise cycle. And there are those exercises that are actually some of the most sophisticated and complex. What this means to me, and I hope it means to you, is that you may have been involved in an escalating or incremental move towards the drill through discussions and planning, through tabletop exercises and other lesser activities. Therefore, some of the things that you have done in assembling the right groups and writing the right kind of policies, procedures, and plans all should have taken you a step closer to executing something like the drill. But the drill is not an entry point by any means. Now, the other thing to say, again, in starting, is when you take a sort of course in exercise design and development, you're really looking at a multi-day class where you're immersed in that. There's a lot to know. And the reason I bring that up is I want to set realistic expectations. In the program today, I'm going to introduce key concepts, and we'll go a little further in terms of our agenda in a moment, but it will not be exhaustive. There's probably a few aspects of this in which you may walk away and say, wow, I wish the speaker had addressed this or that. Please get that into the questions, as Lisa mentioned, into the chat box so we have those and maybe can handle them at the end, or at least I could point you in the right direction to learn more. Now, the other thing Lisa said as a way of introduction is my background is actually as a clinical psychologist and an EMT. So my whole career has been bringing together the disciplines of emergency medicine, emergency management, and kind of the psychology of thinking about people's behavior, really in a concrete way, what people do and what they don't do in emergency conditions. And, also my background is the fact of having been a responder to both the 9/11 World Trade Center attacks, the 93 World Trade Center attack, the Anthrax Screening Center, and places where I did get an opportunity to be very, very up close and personal with human behavior in those most extreme crisis conditions. And we'll try to share a little bit of that experience, a little bit of that, those ideas in our discussion today. But let's be clear in terms of our launch pad here and our objectives of where we're going. Key concepts in design, facilitation, and evaluation of a hospital-based active shooter exercise. And as a default, because hospitals being so unique unto themselves become even more unique when you drill down into different departments and different functions. It may not be your unit, your program, or your department of concern today, but as a default, I'm going to speak primarily about our thinking and designing an exercise for the emergency department. Talk to you about the logic of that in just a few moments. In the program, I hope to share some useful resources and best practices, things that you can download and find online or get from other sources to move you forward in your mission to conduct an exercise or drill. Talk about realistic expectations, try to raise awareness of different pitfalls and problems you may encounter. But bottom line is I hope by the end of the 50 minutes or so, you're in somewhat of a better position for having spent the time together with Lisa and I to move forward in some sort of effective and meaningful drill. As I said, when we think about exercising, full-scale drills and even functional drills are kind of the last steps in a series that become increasingly complex and increasingly sophisticated, increasingly expensive, increasingly time-consuming as you move towards this. And it certainly is important to move towards this, but this should not be your entry point. So for some reason, your organization is kind of new to this idea of an active shooter drill. Please do not rush into it. Make sure that you have done not just the pre-work in developing the drill, but make sure you've actually followed a logical pathway and progression moving towards a drill. You will need all of the information you develop and all the lessons you learn to actually have a fruitful drill. The last thing you want is to set yourself up for some sort of failure where we walk out of the drill and you've actually undermined confidence in your staff, in your administration, in your patients, in your community, that, wow, we did this drill and we really did not handle it well. There obviously will be lessons learned. There will obviously be places we come up short. That's part of the purpose of doing the drill. But we don't want to set out with failure in mind. We want to set out that this is going to be meaningful and we're going to get something positive and useful out of the experience. As I said, because it's going to be time consuming and to a degree expensive when we think about all the moving pieces. So knowing that they're complex, knowing they're sophisticated, knowing they're time consuming, why? At most bottom line, for me at least, and remember where I'm coming from as a behavioral scientist, we understand that under crisis conditions, people do not rise to the occasion, they fall to their training. They're going to fall back on what they have been, again, instructed in, they've drilled, they've exercised. We could have a whole discussion in the deeper psychology of how do we get people in that sweet spot of not terrorizing or traumatizing them in the conducting or discussion of our drills and exercises, and actually make sure they're able to execute, even though in high levels of stress or fear, execute the tasks and the actions that they need to. But the actual active shooter event has such a steep learning curve that this obviously cannot be a plane that we build while we're flying it. We need to have all that time ahead, before the event, to put ourselves in the proper state of readiness for something this dynamic and as potentially devastating as an active shooter event. So wherever you're at, wherever your current level of sophistication or readiness is as an individual, as an organization, I think I've got some material here that's going to help you move it a little bit towards, move the needle towards the next level. A few things to think about, and this should be in the back of your mind to everything else I say during the webinar, and hopefully everything else you do in the preparedness, the execution, and the evaluation of a drill and exercise. And it's this first statement. Exercises are intended to test plans, not people. That will be important as a mantra for you to repeat many times through the exercise development process. When people start to get antsy, they start to get nervous, that they or their team may fail, that they may be shown in the exercise to be not up to the task or to not be able to handle the stress of the situation. That is not the point. The point is not to test individual people or teams of people. We're looking for flaws in our plans, our policies, our procedures, and we want to surface these in drills and exercises so they can be corrected. You obviously don't want to find out about some sort of gap in your plan during the actual crisis event. But when we think about something as terrifying as an active shooter event, a couple things to remember, and I'm making some assumptions that you have some familiarity with the dynamics of active shooter events as well. The current FBI report tells us that in those instances where they could ascertain a timeline, just about 70% of these are over in 5 minutes. So this is going to evolve very quickly, and it's not going to leave you with a lot of time for kind of decision making. You have to be able to move through that cycle of denial and indecision and into very effective response almost instantaneously. So with that in mind, we go back to these ideas that people fall to their training, that we are there to test the plan, and we want to take some of the stress off of people, understand that they are not what's under the microscope, the plan is under the microscope. That's really kind of our overarching thinking about the drill. Now, as I said, this makes some assumptions that you have all these other things ironed out before you even start thinking about a drill, and that means policies, plans, procedures related to violence prevention in general. And then as a subtype of violence, the most extreme, the most devastating, but the most statistically rare is the active shooter situation. The vast majority of violence that occurs in hospitals and healthcare is what we refer to as type 2 violence, which is patient to staff. So you, from my standpoint, your violence prevention posture should be all-inclusive, and you should be thinking about a continuum of violence that ranges from verbal and physical abuse to that violence that may involve a weapon to the very rare occasion that that is a firearm and it's a shooting event, and even as a subtype of shooting, an active shooter event. So we're going to talk more about that in just a moment. The other part is to compartmentalize your drills. You obviously can't do a hospital-wide active shooter drill. It may mean, notifying, it may mean activating different parts of your hospital, but given the nature of the work, it's not shutting the hospital or going offline in some way in this global way to run the exercise. We want to think in a very, very kind of surgical way, what departments, what functions, what areas do we really want to test, and settle on that and compartmentalize it. But please notice my last bullet point of this slide, conservatively figure on a 4 to 6 month window of planning for a full-scale exercise or drill. This is nothing that you can rush towards. If someone were to say to you today, folks, we need to have that exercise by September 1st, you really need to, you need to push back on that and say, I understand the urgency. We want to do this right. We want to do this smartly, and this is going to take time. So you do have to give yourself time in the development and the delivery. Now, as I said, my kind of area of expertise is largely in the behavior of staff, of patients, of the incoming law enforcement teams, of all of these people. And this is also part of why we're testing, is to, for at least our team, to put them in a realistic simulation so that on that day, on that very bad day, should you actually have an active shooter event, the dynamics are not completely unknown to them. The dynamics are not completely novel. It's going to be overwhelming. It's going to be terrifying. It's going to be traumatic in a real shooter event. We do not do our teams any good by sugarcoating the simulation. You want the simulation to be realistic, and that means by its nature, you're also going to have to make it a little bit frightening. There are no happy active shooter drills. There's no happy active shooter training. This, by its nature, is discussing a horrible, brutal event, and there's not a benefit to kind of downplaying how serious and how scary the event may be. You, though, also have to anticipate with a degree of reality what your staff, what your people are actually most likely to do and not do under that level of stress. Absent of doing that, if you're not operating on what I'm going to refer to several times in this session as accurate behavioral assumptions, you're not doing yourself or your team much of a favor. Now, Lisa made reference in her opening comments about the shooting in the Florida hospital just about a week ago. And the reason I bring this up, and I know Lisa did as well, we spoke about this case when it happened. We exchanged some notes and emails very quickly about it. It was actually kind of very representative of many of the shootings we do see in the emergency department. So I want you to think about a few things. First of all, obviously active shooter incidents in hospitals are a different sort of scenario than the shooting in the mall, the shooting in the school, the shooting at a movie theater or a nightclub. There are things that are very different about this. So you cannot generalize. You cannot take off-the-shelf kits, templates, or manuals about running active shooter drills and just generalize them to your hospital or to one of your departments. You actually need to be finding resources that are specific to hospitals and healthcare. The other thing is you need to think about the realities in those units and departments, because what shootings look like in emergency departments, which is actually one of the most common places, is actually different than what we see on the medical surge floors, on the inpatient units, and other parts of the hospital. Obviously, if you're going to structure a drill and write the scenario, you want to do this with a degree of reality. Not just, making it scary, but making it representative of the kind of shooting event you are most likely to encounter. Well, one of the most common scenarios in the emergency department is a prisoner who somehow wrangles a weapon away from a law enforcement officer or security officer at the emergency room level. Another scenario like that is someone who's brought in their belongings or not yet has been properly patted down or checked, has brought that weapon in. But one of the most common is taking a weapon from an officer. What that means is most of those shootings are impulsive, right? So the person had this, they thought they had this opportunity. They're using the shooting as a way to flee, but they did not come into the ER or the emergency department with that classic active shooter mentality. And what does that mean? Well, the classic active shooter mentality is someone who's looking for a populated environment with, limited opportunity for escape. They're looking for numbers. So this is like our shooter in Aurora, Colorado, who shoots up the movie theater, or one of these places like the nightclub in Orlando, where it's densely populated with limited opportunity for escape. This is not the dynamic. The dynamic in the emergency department tends to be impulsive with random target selection. Shoot the officer, shoot some other people, and try to escape. When we have shootings in inpatient settings, on the med surge floors and other places, they tend to be different. They tend to be premeditated. The person has a grudge against someone in the treatment facility. They have thought about the how and the when and the where. They've maybe researched it. And there tends to be a relationship between the shooter and their targets, not random target selection. So we could have a whole discussion around that, but shootings in emergency departments, they actually look different than shootings in other parts of the hospital. So to my point, you cannot generalize that the materials you find anywhere about active shooter drills and exercises apply directly to hospitals, and you can't even assume that the materials you find about hospital active shooter drills are universal to every department and function in the hospital. You really do need to think about that closely and think about how we align our exercise scenario and our exercise objectives with the realities of your hospital, not just hospitals, yours. If you're closer to a correctional facility, if you're seeing more forensic prisoners or patients, if you have a forensic unit in the hospital, you may actually have a very different mix. But here I just want to raise awareness to this without reaching each of the bullet points. Journal of Emergency Medicine News in February, a very good special report And really their question in the title, are emergency departments the most dangerous places to work in America? And outside of a job in law enforcement, the answer is yes, they are, for many of the reasons we touched on, and some we'll go into a little more deeply. So we know that we're in a high-risk environment in any unit of the hospital, in any kind of health care facility. An active shooter event is a nightmare scenario. Obviously, we have people in the hospital who are vulnerable. We have people we can't always move quickly or easily in a run, hide, fight sort of way. It's just probably one of the worst case scenarios is to think about that kind of violence unfolding in the hospital and healthcare setting, which is why we really want to make sure we're doing this right and thinking it through smartly. So lesson one is don't generalize. So I have here a number of documents, two of which you may have seen already, to the left of the screen in the center. These are two really thorough and very useful guides you can find online at no cost. Active shooter planning and response in healthcare settings, a number of different groups, including the FBI, public health officials participating in that, to the center, incorporating active shooter into your emergency ops plans. That's FEMA, Homeland Security, FBI, and ASPR. But most recent, if you haven't seen it, this was published earlier this year in 2015, was the FBI and our medical community coming together for probably what is our most up-to-date active shooter planning and response guide just for hospitals and healthcare. All of those are online. All of those are free. Remember, at the end of the session, you will have access to these slides if you need to come back and see the titles of these. So I also reference here the Hospital Association of Southern California, which has a really excellent online toolkit that, one, helped inform a lot of what we're going to share today, because it is they do articulate all the right moves and all the right thinking. But know that you can find that online as well and drill down into that and see some of the really useful resources they've created for conducting active shooter drills in their settings. Now, another one of my assumptions is that you're using the Incident Command System, or HICS, some version of the Incident Command System. And sometimes as we start to think through our objectives, people will say to me, Steve, we want to make an objective of this exercise in using the Incident Command System or the Hospital Incident Command System. And my message or my feedback is typically, that's great, but that also should be an objective in every exercise, because it should be, the Incident Command structure should be applied to every one of your circumstances, every one of your crises. So whether you articulate it or not as one of your objectives in a drill, it should be in the background always an objective that you'll be applying and testing the interoperability and the resource allocation aspects of the incident command model that you have used. As I said, part of the logic is we know that simply practicing something does not make us perfect. Perfect practice makes perfect. We have to exercise and we have to drill the way we would do, really roll this out in a live event. So if you would be using your incident command structure, the answer to that is, yes, you would. In a real event, then you should make sure it's very present and very much a part of your thinking in your exercise design, evaluation, and facilitation. So we're going to talk very quickly about 10 steps in moving towards a drill. It starts with knowing where you are. So looking at your existing emergency preparedness, I'm going to use the acronym later, EPR. I'll be referring to emergency planning and response sorts of plans and guides. Know what your general emergency response plans are for your facility and your organization. Know what those are around violence in general, not just active shooter, but I want you to remember that this is an opportunity to really integrate something as challenging as active shooter violence into a larger spectrum of potential violence you may encounter in your hospital. So know your violence prevention platform as well, where you are, and make sure that you have moved incrementally towards something as sophisticated as the drill. As I said, tabletops and other lesser iterations of this. Now, having said that, you may already have created the necessary teams when you did your tabletop exercises, or as you're moving towards a tabletop exercise. So there will be a lot of places where you do not need to reinvent wheels in conducting the drill. And that's great news. So some of your players will have participated in tabletops. They'll have learned the lessons. They'll have familiarity with the language and the models that you'll use in the drill, so you're not bringing a lot of novices into something as complex as the drill. Develop your exercises, watch closely. Number 4, number 5, develop the scenario. Those need to happen in sequence. There are times in which, Lisa, let me ask you for a second. Are you able to hear me well? Someone send a message that there's no audio. Are we good?
That was me hitting the wrong button. My apologies. Yes, I can hear you fine.
Okay, I'm sorry. I just got a little concerned when I saw that flash by. So let me go back to that. There are times when folks get just a little bit ahead of themselves. People do get excited about doing this. There's a lot of energy, a lot of pressure sometimes around this, and they start thinking about their exercise scenario before their objectives. Your objectives guide your scenario. You write the story almost last in this process so that it actually pushes the right buttons to challenge the objectives that you have identified and articulated. So this sequence of objectives, developing objectives and developing the scenario, you do have to be mindful of. Start then as you create the objectives, the scenario. That will speak to you about who the right players are. And remember that in a real active shooter event, you're immediately calling 911. You're going to have an external response of police and other sorts of resources. So you have to bring in all those external players right away. Now, some of those you may have identified and worked with in your tabletop or your other lesser sophisticated exercises, but you will need those relationships, and you need everyone to be so clear on their expected roles, responsibilities. You want to hear their perspectives during the planning phase and have all of that ironed out. Now, I hate to say this. This sounds almost counterintuitive, right? But you don't necessarily want a lot of surprises during the exercise. You don't want like a lot of improv. You want local responders to be real clear. You want our internal teams to be real clear on what they're expected. I mean, a phrase I use often is this idea that we need to stay in our own lane. But it's in the pre-work, in developing the exercise and planning and training before the exercise, that we can become really clear with partners of all kinds, inside and outside, about what the expectations are. Then we start moving to things like logistics. Where will we do this? What will we need to do? If this means closing your emergency department or any other part of your hospital for several hours to execute this exercise, will you divert? How will we work that out with our partner hospitals or other facilities? How will we work that out in notifying the public and the community around the fact that we're going to be really immersed in this exercise for a good part of the day? We get that all straight before we start thinking about curveballs. And that's where we're not improving, but maybe we're trying to raise the stakes. We're trying to throw some challenges into the exercise that aren't as anticipated, but they're still structured. We're not thinking off the top of our head. We develop any injects as a formal process. We obviously have to pick our team, our exercise team well, meaning, who are our controllers, our safety officers, our observers, scribes to be taking great notes, and you need to plan on doing a few different levels of after action. An immediate hot wash, a debrief of the folks who participated in the event, and then ultimately on to crafting an after action report so you can capture the lessons learned and move forward in remediation. So it is important to work the system. Skipping steps and doing this anyway in a rush is likely to get you a bad result. On this note, when we talk about objectives, just to spend a moment on objectives, be reasonable and be practical. Somewhere between 3 and 5 objectives is usually doable. When you start getting well beyond 5, it is likely that you're going to exceed your capability to really test that out well in the drill, and you may be setting yourself for a bit of a disappointment. So be modest, be realistic, and also be practical in your identification of objectives. If these are things you really want to test, you really want to see. So be thoughtful about the identification. And you may be familiar with the acronym SMART in the development of your objectives. Make them simple, measurable, achievable, realistic, and task-oriented, so that folks who are expected to execute certain actions or tasks, that's what they will be doing during the drill. So they can see their capability of doing that under stress in a simulated hostile encounter. That's really the benefit of the exercise. So as you do your objectives, which really are so critical, I would suggest keeping the SMART acronym really as part of your framework. Now, our objectives for our webinar and our thinking about kind of like a default exercise, and that's what I almost need to do to facilitate this discussion, is to be thinking through, if I was preparing for a drill, what are the action steps I would take? So I'm thinking about now us today discussing a little bit of a drill for your hospital that's focused, as I said, on the emergency department, and who are the players and how do we start to put that together. Some of our objectives then, if I'm doing something like the emergency department, and these don't have to be your objectives for your hospital, they don't even have to be your objectives for your emergency department, but this is me thinking out loud. If I was developing an exercise or a drill for the emergency department, what are some of the objectives I might select? And one might be the immediate alert and notification that we have a hostile event, that we have a threatening event in the ED. How will I push that out to all those who need to know? And of course, that means me thinking about who are all those people who need to know inside and outside the hospital. And that may be staff that's off duty. It may be our community partners, lots of people to notify. And what are my technologies? And if I'm doing that, what do I need to have in place ahead of time? Is it templates? Is it scripts? How do I make sure my systems are populated with people's contact numbers? All of those things that tie to alert and notification. Internal communication with our workforce as the natural outcome. This is something I want to test. Communications outside of our facility with our stakeholders. And then, of course, that the folks, can actually execute those critical response actions under real severe stress. Lastly, although I said it's always implied whether you articulate it or not, number 5 is my ability to use a command and control structure like the ICS or HICS through the event. Those are just examples. You obviously can craft any sort of exercise or drill objectives that you see fit. Now, 2 things. In my early comments on the webinar today, I mentioned the toolkit from the Southern California Hospital Association. They have done a wonderful job in actually capturing and documenting many of the action steps and many of the tools that we use in exercise design, facilitation, and evaluation. Some of these they've crafted themselves. Some of these were kind of best practices, but it's a great place to look at examples of. And the other thing I've given you twofold. One here I mentioned FEMA's MESL toolkit. Now that acronym, MSAEL, stands for the Master Exercise Scenario List. So this is usually something done on a spreadsheet. This is usually an Excel type of spreadsheet that very much details all the flow of the exercise, what we need, how it's happening, who's doing what, where, and then. As I said, we're trying to reduce surprise. We really want to make sure we know what we're getting ourselves into. FEMA has a great toolkit, and you have the link there. Remember, you can go back and get these slides from us later that you can go to online and really download. And if you're not familiar with the expression or the acronym HCEP, or the Federal Homeland Security Exercise and Evaluation Program, it's kind of a Department of Homeland Security level structure for how we create exercises. And it provides a great kind of introduction to how you build and how you use the master scenario events list. But then you see some other things that, again, the Southern California team has done a great job with, which is helping you create things like victim cards and safety rules and checklists, but even things like sample language for hold harmless agreements and the kind of legal risk management you need to do around your exercise. So we're actually going to talk about that in just a moment. You actually need to bring your legal folks in as part of your team and have them be thinking about different sorts of consent forms and liability issues around folks who may be either physically or psychologically shaken up by participating in the event, in your exercise, not the real shooting event, but just even your exercise. And then we start really embarking on what is a few months of very rigorous pre-drill coordination. And this is with, usually a blend of our internal and external partners. Part of that is deciding who will be filling which structured HICS or incident command system positions, who will be our exercise officials, meaning who will be the controller, the safety officers, the scribes, ambassadors, all kinds of folks who will have different roles. And then we need to start thinking as a group and agreeing upon, what our scenario will be. Our objectives first, of course, and then, our scenario. Is it going to be a security challenge? Is it going to be something of another crisis? Well, obviously, the active shooter represents primarily a security challenge, but it's going to touch on environmental and medical issues as well. Now, the drill committee may require a wide range of different players. And as I said, hopefully, if you have moved incrementally from tabletopping to live drills, you've got some of these people on board already. You need to really cast a pretty wide net because there's very few people, at least in an ED related active shooter event, who would not be tapped, would not be charged in some way. So we need to start forming the committee. Who are those people who are going to be in on planning meetings? How are we going to start to do pre-training for staff? So you'll notice here there's a tab on the slide that says general. So we're doing some thinking about the overarching involvement of the hospital in an active shooter event, and then we need to drill down to unit-specific sorts of folks and disciplines. What do I mean by that? Well, let's think about the emergency department again. The question is, who is likely to be in the emergency department when we have shots fired? Well, obviously it's your primary team of your doctors, your nurses, your technicians. So who else do you have flowing in and out of the ER constantly? You have all kinds of technicians from radiology, you have transporters, you have people taking lab samples like phlebotomists, you have clerical staff at the desk for people coming in and out. You have this whole range of folks, and some of them may actually be external partners like those local EMS squads who are constantly in and out of your emergency department as well. So beyond thinking, as we did in the last slide, in a general way, who do we need to help be part of a team, crafting the exercise and facilitating the exercise? The next level of thought is drilling down who from that specific unit or discipline do we need to envision as being part of the planning team leading up to, not just players and actors during the event, but who should have a voice in this? And if we think that we may have transporters or radiology or someone else in the emergency department at the time of a shooting, we've got to have representation of those functions in those departments in our discussions as well. Obviously, this is going to be a tremendously important relationship demand on our law enforcement partners in our community. The other thing to imagine is casting a wide net depending on your geography. You're urban, you're suburban, you're rural, you're out in the frontier area, wherever your hospital is, who are the other likely responding law enforcement partners? So you need to think almost in concentric rings, in terms of ripple effects. Because if you're in a larger city or an area that has a regional FBI field office, you're probably going to see those folks showing up pretty quickly as well. So it's your local PD, it may be county sheriffs, it may be all kinds of law enforcement partners, and in all different kinds of levels of readiness for this. So identifying all of the relevant law enforcement partners, creating liaisons with them, discussing, working with their training folks, thinking about those agencies who frequent or would respond to your hospital in a shooting event, they all become important. So that's the law enforcement side, and obviously the immediate connection with your hospital security, whether you have purely hospital staff, you use your own security, you use a third-party security contractor, they're armed, they're unarmed, it varies in every circumstance that we work. You're going to need to think through about all those details about the engagement between law enforcement and your security teams. But you now also need to think about your acceptable level of realism. 2 levels of realism. What will the assault look like? So we're making the assumption we're under attack. It's one or more individuals with weapons. how are we going to simulate that? If we want this to be realistic, or law enforcement going to be using blanks? Or are they going to be using simunitions, things like, paintballs or more technical simunitions? Or are they just going to walk through with real weapons, disabled weapons, rubber guns? This is things for you to negotiate with your law enforcement partners and with your teams. And then the reality about your casualties. Do people just lay there? Maybe they have read a card that says, you're dead. You've been shot in the arm, and the third person has a different kind of wound. Do they have some sort of triage tags on them? What will that look like? Or do you go to some higher level moulage in which we have simulated wounds, and our staff needs to go hands-on with these folks in appropriate ways as per the nature and severity of their injuries. Now, part of this also is for victim scripts. So we're going to talk about victim cards later, because we don't want our victims improvising, right? We want them to have a clear idea about what the nature of their involvement is in the situation, their nature of their wound. As I said, we also need to think about associated legal risks. This is right from the Southern California toolkit that gives some example of language in different liability statements, releases and waivers and agreements of consent, things that say, I'm aware that I'm going to participate in something that may be dangerous, and I give my consent. And I understand that I must fully comply with all directions of our safety officers and law enforcement partners. And I understand this is going to be, very stressful and a little bit out there, and I accept these risks. So you do need your legal team to anticipate what are the legal risks associated with just doing the drill, not just the risks associated with a shooter. And then as we start to have those things ironed on, we start to ready our players. We start to ready our units by having awareness level campaigns that we're going to be doing this, having conferences and workshops that people, again, become familiar with our violence prevention postures and our policies, that everyone moves into this with a level of readiness. The drill should never be a surprise. You can't do this as a surprise thing. As I said, we also need to be thinking about all those other moving parts you need to put in place ahead of time, including things like Trump. Yes, Lisa.
I apologize. We're getting actually a few people saying the audio has cut out. Can people just let me know, is the audio back?
Well, you hear me, right, Lisa?
I can hear you fine, yeah, but there were 3 people all at the same 4 people.
Okay.
Okay, so let me type it in the answers. I'll send it to all. Try calling back on the phone number if you. I am on the computer. There's also a computer button that you can hit. So sometimes switching to computer audio can make a difference if that's an option that you guys have. And then I'm getting a whole bunch of people can hear it. Okay.
Okay. So we're going to make the assumption that most people can hear it, and that if they can't, that they can download the archive version, which will hopefully have all the sounds, since you and I hear each other okay.
Yes.
Okay, having said that, we're still on the theme of pre-drill conferences and education. It is also bringing in our partners from local law enforcement, EMS, and other folks as well into those discussions, those trainings. And we need to do a very thorough briefing for the players. And part of the theme for this, and I'm going to kind of pick up the pace a little bit, Lisa, because we have lots that I still want to share with folks, is that people need to understand that this is, it's intended to mimic a real shooting event. So it's going to be noisy, it's going to be confusing, it's going to be anxiety producing, and that's the nature of a real shooting event, that we're not trying to sugarcoat this. We need people to understand that, and this is what's referred to as prior or notification of the nature of events, is they need to understand that these things can be emotionally upsetting to people. That should not come as any sort of surprise. They also need to wear some sort of PPE or personal protective equipment, and that the simulated law enforcement response is going to be realistic. Officers may be yelling and screaming and shouting at them and pushing them down, and it's going to be really, really stressful. Everyone should know that, including the fact that there's likely to be a simulated shooter. And the shooter, who in most instances we select as, a law enforcement officer, will be carrying some sort of weapon or weapons, will be discharging perhaps blanks or munitions or something of that nature. But people need to understand that there'll be that level of reality. We don't want them surprised. Now, part of the way we couch against the risk of that is to make sure we have the security officer and that he or she really puts a very robust safety and security plan in place. And that includes very simple things, that making sure every communication begins and ends with those statements. This is an exercise. Having an emergency code word that if someone said that would alert us that there's an actual emergency inside of our drill, that we need to suspend the drill perhaps. And also the idea of visually identifying clothing, that things like vests or armbands and other really, really clearly clothing or materials are visible from across a distance where people can see who those exercise officials are, reach out to them, and grab them in an instant if there's some sort of problem. So everyone needs to understand the key positions and how they're identified. Beyond that, we need to start thinking about the victim role. So the shooter needs to be clear in terms of what they're doing. Our victims need to be briefed on what they're doing. As I said, we don't want victims to improvise. We want them to have some clarity in what their role is. Yes, they can be as dramatic or non-dramatic as they want. That's going to fluctuate. But if you're someone who was shot, we want you to understand the nature of your injury and stay within the parameters. From there, to help make sure people can execute, we tend to create job action lists and job action sheets that really, drill down and articulate for the victim and for every role what the specific tasks are that we're imagining that people can execute. And in doing so, we eliminate, as I said, some of the surprise as we do that as a part of our pre-exercise development. We sometimes identify deficiencies. Well, someone says they're not sure they could do that. What awareness, knowledge, or skills would they need to do that? We could go back and fortify that in training. You want to think ahead of time about signage. Signage in general to let people know that there's a drill in progress. Signage in the days before. Signage for guests and visitors who may be coming into the hospital, that they're not surprised or frightened by the event as well. And like that, be thinking and communicating with our staff, really sharing with them all of our different communications issues, our different challenges around communications, but also our different technologies. How will people know? What kind of messages will they receive? What they should do with the messages? And use this as a way to test that out as well. But the last and somewhat most important part of the whole process is the debriefing and hot washing after that leads to a formal after action report. This is almost what the whole purpose of doing this. This is where we capture the lessons we've learned in this. So we need to ask essentially some very structured questions in our hot wash. And these are the top 5 questions. Can we identify the top 3 strengths? What are the things we did very well? Move on from that. Can we identify 3 areas where we were not as strong? Areas of improvement that we can go back to. And lastly, before we move on to the external questions, what else would we need to do? What additional efforts or planning, did we surface through this process that we really want to capture and remediate before we have a real event? The kind of secondary questions, number 4 and 5, did we identify any additional community partners who should have been part of this, but they weren't? And lastly, did we identify any kind of specific training needs that we hadn't previously done, but would really help us before we do an exercise like this again, or before we have a real shooter event, the kind of training people would need. So let's wrap up with some lessons learned about exercising and about drills. 1, the pre-planning for all the roles and all the relevant groups is critical. We don't want to be leaving people out. We probably want to be over-inclusive rather than under-inclusive, and all this requires a good length of time. So allow time for the development of the exercise. On the exercise day, be realistic in how long you're going to play it out. Allow the scenario to fully develop and play itself out. Don't rush to the exercise once you jump in. It can be stressful. It can be frightening. It can be, again, very fast moving, but you want to make sure you've built enough time for that. Have enough exercise staff on hand to control and monitor this. You don't want your exercise teams to feel overwhelmed. And be realistic and behaviorally accurate about the sorts of behaviors that our shooter would be involved in, our staff would be involved in, incoming law enforcement partners would be, again, doing or not doing. You really want to make sure there's a degree of reality and a degree of accuracy around the behavior. Be incredibly clear about the ground rules. There will be, by design, some level of chaos and confusion in the exercise, but people should not be confused about their roles. They should not be confused about the nature of the event or what they're expected to do. And make sure you budget time and inform people that you want to do some sort of debrief immediately after the exercise, so people aren't like, okay, that was, glad that's done, I need to get back to work. You need to budget some time in that day to do a debrief, make sure people's heads are on straight at the end of the exercise. And at that time, don't feel you need to have all the answers. If people say, hey, we found this big gap or deficiency in the exercise, during the debrief is not the time to answer that. So use this as an opportunity to test your larger emergency prepared response plans, your hazard-specific responses like violence, and very micro-specific, something like active shooter. Be realistic for people on site. Be realistic if there are folks who are participating off-site by calling in or web-based response, things like that. And as I said, documentation becomes critical to us, making sure we're really capturing this and writing all this down so we can use it to go forward. Using it to go forward, keeping dialogue alive, using it forward, playing it forward for creating our next level or cycle of exercises, and continuing to up the ante in terms of the level of sophistication and challenges in future exercises. As you've heard perhaps said in a number of circles over the years, we don't practice until we get it right. We want to practice until we can't get it wrong. Lisa, that's my story, and I'm sticking to it. We have a few moments for you to share some information, and perhaps for a few questions before we wrap up.
Steve, thank you so much. So one of the great things about Steve is how incredibly thorough he is when he gives a presentation. So thank you again so much for that. That was the first time we did it specifically on this topic, and it was great seeing all of the information in there and the resources. And one of the things to really think about is, when a crisis happens in general, not just active shooter, but really anything, it's hurricane season, what do you need? You need to be able to locate your staff. You need to be able to assess the situation, understand what's going on. You need to know what kind of supplies and facilities you have on hand. Do you need housekeeping? Do you need to contact the local community and the police and fire like we would during an active shooter incident? Do you have enough medical supplies on hand to handle the incident if it occurs? Do you have a way to track the information, reach employees, make sure that everyone stays safe? And, again, how are you working with that outside community? I did put the microphones down there in the bottom right because that's actually one of our questions today is, the media is going to be involved. And as we showed in one of the early slides in Pennsylvania this weekend, the local news is covering an active drill. So how are you going to handle that? The way Everbridge can help you is we can help you control your command center. This is from an active drill that we did in Austin, Texas with Seton Medical Center. Everything is mobile, so yes, you can be in the command center, but you don't have to. You can execute plans from anywhere. We do help you stay in touch with the local community, either from police, fire, all the agencies that you're working with, but also people, in the waiting room, people in the local community that might be affected by something happening. We do have a very extensive resource library for CMS emergency preparedness, so definitely check out that page. And we also have an Everbridge General Hospital test environment. If any of you are interested in demonstrations, we can bring you in. You can try to break it. We've had many people try. Nobody's broken it yet. So, and we can show you how to execute. We actually have templates for active shooter. You can launch those and see how an incident plays out in real time in our test environment. Okay, so kind of going back to that first slide, how do you integrate the media when you're performing an active drill? Do you have any tips, Steve?
Well, like much of what we discussed, Lisa, it begins with getting them involved early on. They may not necessarily be part of your committee in planning and designing the drill, but there's probably a place where you want to have some sort of media briefing. You want to be working, obviously, with your internal communications specialists and your community affairs folks in your hospital on how that's going to happen, because it's an opportunity to have the right kind of coverage, really to demonstrate to your community that you're doing this proactively and your hospital's in a state of readiness for a crisis like this. Also to help inform people that, on that particular Saturday, something might be going on down at their community hospital. So I would say a few things. You have a need through exercising the incident command structure to be thinking about these communications channels with your public information officer from the command side, with your internal communications people on the hospital side, employing your different communications technologies, as you just touched on. So communications should always be a part, and then depending on your identified objectives, it actually may be, the interface with media control, media management, or communications, crisis communications, may be articulated as one of your specific objectives. So having said that, at a minimum, you can look towards reaching out to editors and leaders in your media market to bring them into the discussion early, having them perhaps have some sort of role during the event. And you can even raise that to the level where they may be a player, which means one of our objectives would be, how will we, where will we put the media? How will we communicate with the media? How do we craft our crisis communications and make that a formal objective? So it's a little bit of a wishy-washy answer because it kind of all depends, but they should be involved, the media should be involved in some level in the whole drill situation.
Thank you. And I would add that it's also an opportunity to create goodwill within the community, that you're showing them that you are prepared. You're showing them, your level of commitment to keep the community safe. And especially with, there was an attack in the last 3 weeks. There's been 2 attacks in hospitals. It gives a sense of comfort and safety to the local community that you guys, you're on top of it and you know what you're doing and you're going to be able to keep people safe.
So doing this with some level of transparency, as Lisa said, is really helpful in the larger mission of your hospital.
Yes, thank you. And then one of the questions we got in is, how would you continue to operate and accept patients during an active drill?
Well, there are 2 ways to do that. Really, it depends on your hospital and your relationship with surrounding hospitals and how close they are, actually, a number of factors like that. It could be that you're partially closing your emergency department and you'll still in some way be serving patients. It could be with relationships with the hospitals you divert to, that you're actually not going to be accepting patients during the period of the exercise. So there's a number of different models for that, and it does mean that your partner hospitals, those in your region, probably do need to be part of the whole, really design and development of the exercise, thinking realistically, if I do the emergency department, what does that mean to us if we're not able to fully or totally accept patients for the duration of the exercise? What it means in a very general way is you do have to anticipate disruption of ER services to some level, but you get to pick the level and then think about what do we do for that? What is the way to do that? And it's kind of, some modification of your normal divert mechanism. What do you do when you're just swamped? What do you do in a mass casualty event when you hit surge capacity? So you're using some of your surge planning and you're using some of your mass casualty event or mass casualty incident planning to anticipate, an internal disaster as opposed to an external disaster. So I'd refer you a little bit back to your external disaster plans as a starting place for your thinking.
We look forward to seeing you all soon. And Steve, thank you so much for coming today.
Thank you, Lisa, and thank you, everybody, for joining us.